As with the first half of the day, we'll be having a panel to provide their insights into this case. In addition to the two Dr. Tans who can join on stage, we also have two others who will join in the panel discussion. The first is Ms. Nawira Baig, who's a peer support specialist with IMH, who started work at the Slow Stream Rehabilitation and Pilot Recovery Center, currently works as a medical social work department there at IMH. We also have Chan Lei Lin, who is principal medical social worker at IMH, and she is the social work education lead and has extensive experience in community-based social work and medical social work. Please do take your seats up here. Right, so what we have now is actually, it's a single case that will dominate the rest of today, but it will get progressively more complicated as we go along. We'll start off with the beginning of the case, so to speak, and we'll start off with another poll everywhere question that'll come up in a few minutes. Okay, so here is the case that we're going to be discussing. Miss T, 26-year-old lady. She is single and unemployed, stays with her mother in a three-room flat. The mother is a widow and works as a hawker. Growing up, Miss T was mostly raised by her nanny, who was a close friend of her mother. Several years ago, Miss T was seen by a private psychiatrist and was diagnosed with suffering from OCD. She was on psychiatric medications for 3 years, but stopped thereafter. She also stopped seeing her psychiatrist. In the meantime, she also continued her studies at a private university, majoring in psychology. However, during the pandemic, Ms. T's OCD symptoms worsened. She hasn't left the house in the last 3 years, so basically since the pandemic began, and spent almost 24 hours in the toilet to ensure her bowels were clear and she had cleaned herself up properly. She had been experiencing bleeding in the rectum over the last 12 months and started to worry that she had cancer. Ms. T's mother stopped her work to take care of her daughter. Ms. T would get her mother to pass her toilet rolls during her toilet rituals, and her mother was instructed to count in a certain fashion before passing the rolls to her. If this was not done according to Ms. T's wishes, she would compel her mother to hit her, that is, compel her mother to hit her mother's own head 10 times. If the mother did not comply, Ms. T would scream at the top of her voice and disturb her neighbors. This was but one of many cleaning rituals that Ms. T exhibited. Ms. T told her mother that she had learned enough to manage her OCD herself and did not need professional treatment. How would you advise Ms. T's mother? So I'll give it a minute or so, or less than a minute, to answer just this one multiple choice question. Yeah, so the three options were whether to ask Ms. T's mother to persuade her to see a psychiatrist and write her a letter accordingly, call the police and ask Ms. T to be detained for compulsory evaluation at IMH, or to inform Ms. T's mother they can do nothing because Ms. T is not their patient. All right, so we have a strong majority giving the advice option, ask Ms. T's mother to persuade her to see a psychiatrist. About 20% went, so a minority, but a strong minority, one might say, saying that a police report, or a police call anyway, might be necessary, and only 6% with the do nothing option. Okay, so maybe before we get to our panel for their perspectives, I'm wondering if anyone is willing to stand up and explain or defend their answer, either from the majority or the minority position. Anyone will explain why they thought either asking Ms. T's mother or calling the police was the best option.
She's not a danger to herself, she's just a danger to her mother's constipation. She's blocking the toilet all day. Yeah?
Right. Yeah, so thinking back to the criteria of Mental Health Care and Treatment Act, right, a danger to self or others, you might think this case doesn't quite meet that bar, so it wouldn't yet be at the level that police escalation might be warranted. And again, also the first recourse, right, to allow Ms. T to go of her own accord would be in the patient's interest. Anyone who said, though, the second answer, the call the police, wants to defend why they thought, contrary to that, a police report or a police request might be necessary here? No one quite willing to say publicly. It might be, once you see the majority rules and you're in the minority, I understand. But, it is fair enough. There's going to be reasonable disagreement over these cases, and the answers aren't necessarily obvious. Let me now pose it to the panel and get the panelists' initial responses on this first question. Did you agree that the second response is premature, or would there actually be a justification for a police report in this instance?
So your question was what I think of the first answer.
So would a police report be warranted in this case?
Okay. When I was reading, okay, maybe I just digress a little bit. I love to digress. I'm sorry. Very bad at answering questions myself. So, okay, see, I'm a psychiatrist, right? So, so when I go to church or whatever social setting, right, invariably somebody will come up to me, oh my God, my daughter is like that, my colleague is like that, and then I find myself giving a lot of informal advice, which is, I don't know whether it's legally or even ethically defensible. So it feels like one of those scenarios now. Okay. When I was looking at this question, I was actually, I was surprised that there was no option 4. That. Why you all laugh? But okay, anyway, so no, okay. But for me, option 4 might have been something like, as a GP, right? Why don't I maybe get an opportunity to speak to Ms. T first? Why immediately go and send to psychiatrists, you know? Because, I mean, like it or not, I feel that there is a bit of a stigma to mental health and seeing a psychiatrist. I think the domain of mental health is not limited to psychiatrists or psychiatry. I think even general practitioners actually do have a role in at least doing a bit of a preliminary evaluation first. It might actually be less scary for the patient as a start, you know, to see the GP that she knows, that she's familiar with, before immediately, you know, sending for psychiatry. So that's my first thought. The second thing that crossed my mind was we're always very focused on Miss T. Don't forget the mother. Yeah, because the mother is the one that's seeing you, and the mother is very desperate and she's very depressed. Remember what I said, happy carers equals happy patients, right? So, I mean, we are so focused on Miss T and what we should do. Should we call the police? Should we write a memo and everything? But I think don't forget the mother when whatever you decide to do with Miss T. And obviously bear in mind that whatever decision that you make for Miss T would invariably affect the relationship that Miss T has with the mother, because the mother approached you. So which is why I think there should be an option 4 where I would like to see the patient first. I would like to understand what's actually really happening. Because sometimes maybe the mother is exaggerating, you know, we don't know, you know. So yeah, those are my thoughts.
Thanks very much.
Okay.
Well, I suspect that there's a possibility that Ms. T would not turn up in the GP's office. And I thought that there could be a possibility, instead of mom referring the young lady to the psychiatrist, is for the GP to refer mom perhaps to our colleagues in the community. These are people, social workers and counselors, who are helping persons in the community with mental health conditions, or refer them to family service centers, where they could go to the home and try and meet up with Ms. T and see whether there could be a less coercive way of getting her into treatment, trying to understand what are her belief systems about what does she want to do with her life, what's her thinking about being having a mental health condition, anxiety about loss of control and stuff and that like that. So really, someone to really get into understanding where Ms. T is coming from and using a less coercive way of getting her into treatment. So that's what I was thinking. I think this question about question 2, how is it that 18% of the people say that should call the police? I think in section 7 of MHCTA, the police is supposed, is given the authority to actually bring in someone who the police believe to be behaving in a way that looks like the person has got a mental health condition, and at the same time is showing behavior that shows that he is at risk of harm to himself. That means he could be suicidal, or at risk of harm to another person, who he could be harming another person. So the police could actually then bring this person into a mental health treatment facility. But in this case of Ms. T, I think the gentleman over there is right, that there is no imminent risk of harm in the narrative. So option 2 would not quite apply. Yeah. You want to add?
Hi, so I'll be commenting more from the lived experience point of view and also as my role and as a peer support specialist working with other peers in a mental health context, right? So I agree with what Dr. Marcus said about there should be an option for mainly because I don't see, from the patient's perspective, right? I don't see how, the doctor might be able to better advise without actually meeting Miss T. But I also recognize that what Lilian said, that she might not turn up at the GP's office, right? So I also wonder how much of this can be managed in the community and how necessary it is for Miss T to actually turn up at IMH. Also because she's quite young, she's 26, right? She has her whole life ahead of her. She's single and unemployed. I might want to also understand better why she's quite resistant to seeing a psychiatrist and taking her medication, especially when she actually once, was seeing a psychiatrist and taking medication as well. So understanding a bit more of the barriers to her seeking help. Why is she now resistant? I felt like maybe that could have been explored if someone from the community visits her in a place where she is more comfortable as well, where she might be more open to sharing how she really feels. Yeah, so I also agree. It's also probably about hearing a bit more from Ms. T. Maybe because she's also concerned about the stigma, not just social stigma, but also self-stigma probably. So identifying what are the barriers might be helpful at this stage. Yeah, thank you.
Thanks very much. Giles, did you want to weigh in on this? Could I just return back if the audience, we had a second question which is actually very related to this, but maybe it's the inverse sort of question, which was about, in this particular case, the importance of respecting Ms. T's wishes on not seeking professional treatments. We heard, it's better to engage more with Ms. T. At the end of the day, right, there's a question of whether or not to respect the treatment. Did anyone else from the audience want to chip in on whether or not Ms. T's mother should bring her to IMH, nevertheless, despite Ms. T's reluctance? So I might pose the question to the panelists, just to expand a bit on, I think, what we were getting at with this question. In this case, we see maybe Mental Health Care Treatment Act might not apply. Would it nevertheless be prudent for Ms. T's mother to actually take the proactive step of bringing Ms. T along, or is that a step too far? Is that crossing a boundary, depending?
Yeah, perhaps I can make a comment. We can't use any legislation here. So this would then be in the province of engaging with the patient, understanding how best we can, as healthcare professionals, help this patient. We can't compel the patient really to do what she's not willing to do. But if we understand the reasons why she's not coming forward to seek help, then we can then perhaps address some of these areas of resistance, and in the course of it, building up some trust with the patient, and hopefully the patient then perhaps is more accepting of treatment. It sounds like in this case, the mother seems to be the one more troubled by the symptoms than the patient. Of course, the patient does have some distress from the symptoms, but the mother is probably very much inconvenienced and distressed by what she has to go through as well. So I think really we do have to respect her wishes at this point in time not to seek treatment, but it doesn't mean we don't do anything. I think we try to engage and we find ways of facilitating what her needs are, assessing them, and then maybe then trying to engage her to get help subsequently.
If I may just chime in, right? I had a very interesting discussion with a colleague from Malaysia from palliative care, and she asked us about harm and potential harm to others or immediate harm. This is the question that came up, was how do you measure that harm? Must someone get injured first or bruised before there's harm? If there's ongoing psychological distress that the mother is experiencing, is that justification enough? I don't think there's an easy way to measure this, the clear psychological harm, which is why I feel that for the GP side, to look at the mother first, to see how distressed or how desperate she is I think that would actually guide his or her decision as to whether or not to respect Miss T's wishes or to follow seeing what's being done to the mother. The mother is also subject to the patient's OCD rituals. We see this a lot in obsessive-compulsive disorder. Sometimes the person has rituals on his or her own, but they also involve all the loved ones in some of their rituals as well. And in this case, the mother is expected to hit her own head if the ritual is not followed. So I think if the GP sees that, oh my God, the mother has bruises over the head already, and then she's subject to all these things already, I do feel that it's justifiable to activate higher levels of services to engage Ms. T. Obviously, we still want to respect her autonomy, but I think it really depends on what the mother is. So that's why I say, don't forget the mother. We focus on Ms. T, but don't forget the mother, because she's the one who comes to you. Yeah.
Back to this issue about referring, I think this is a case where it's very clear that the entire family system is not working. The young lady is spending 24 hours in toilet, and she screams when the rituals are not done. I'm sure she's going through a lot of distress. So is mom, who's intimidated into abusing herself. Right? And mom has to stop work to care for her. So the whole family system, I'm a social worker, so I don't work just with my clients, I work with my clients and the families. So we also need to look at the family system, like what you guys said. What I feel is it's really important for perhaps a home visit to be done to assess and corroborate what mom has been telling us and to see how serious is the case before we actually consider looking at a mental health, a referral perhaps to IMH. So I think that would be one thing that I would recommend. Anything like that?
Yeah, I mean, I agree that, like the mom is also involved, and then it can be, the mom is getting hurt as well. But yeah, I do feel that there's still, a way that we can still respect Ms. T's wishes, especially since I think that she also mentioned that she can manage this on her own. I think I'm trying to understand from her, how she has been managing and what her understanding of managing her condition would look like. Because I don't think that we've really heard that part of it. And trying to understand what more she thinks can be done if she already says that I can manage my condition. Yeah, so I think recognizing that part might be important as well. But I also recognize that there is risk of harm to her mom, and there are other people involved. It's not just Ms. T. We shouldn't be looking at her in isolation as well. But I think at this point, whether it's necessary to immediately bring her to IMH, or like I mentioned earlier, can we still explore other community resources that are relevant to mental health, that Ms. T might be more open to.
I think certainly this is one case that must be brought to the professional, depending on which level, because in the Singapore Mental Health Study in 2016, it was established that persons with OCD generally take 11 years experiencing the symptoms before they finally end up in the professional's office. So we cannot ignore situations like this. We have to think of very creative ways to enter into the family system and to bring them into treatment in the most non-coercive way as possible.
Thank you.
Actually, I agree with what Lei Ling says about the least coercive way and the more creative ways. There was a mention about calling the police, right? I just saw a patient 2 weeks ago, bipolar lady. When she was in relapse, the husband called the police, and the whole police descended upon the neighborhood. There was a manhunt for her where she was, and the neighbors were looking, and then she felt so traumatized by that incident, not by the admission, but or seeing the doctor or taking medication, but the fact that the police were called. And every time she comes to see me, she asked me, "Are you going to call the police again?" It wasn't me who called the police. Yeah, it's probably one of the 18% there who called the police. It wasn't me. Yeah, so it wasn't me. But I think we have to tread cautiously, because I think everything we do, we think it's in the best interest, right? But sometimes there are these long-lasting ramifications for the patient as well. So yeah. Sorry.
Thanks very much for that. We now have a bit of our own, we talked about covert medication earlier. We have our own sort of covert elaboration to this case. So maybe we could distribute now part 2 of this case, which is a second development here for our understanding. This is, I don't think this is in your packets. This is a thing that we're going to be distributing to tables now. Marcus is going to go around, others will go around and hand out the case packets. We put this kind of second so we wouldn't necessarily have too much overthinking of this, and we can get sort of immediate reactions on first hearing about this case and how you feel about it. Then we'll have a bit of panel discussion for further investigation. Okay, while the case is being handed out, I'll read it out a little slowly so we can digest it. So part 2, same basic details, but this is a further development, okay, of Miss T. At your recommendation, the psychiatrist's recommendation, Ms. T's mother called IMH, Mobile Health Crisis Team. A team of mental health nurses was activated and brought Ms. T to IMH. She was warded in the inpatient unit. During her stay, Ms. T was compliant to the psychiatric medications prescribed by the ward team. She continued to spend up to 4 hours in the toilet, although she tries to be compliant with the ward routines and agreed to be compliant to her medications on discharge and to return for follow-up. She was offered psychological therapy and family therapy, but she was not keen, saying that she was feeling better. She also refused further investigation for her rectum bleeding. You're also concerned as she has not been eating well and has lost weight. As the inpatient doctor attending to Ms. T, you feel that she needs psychological therapy. So the question, and we're going to pose this to another poll EV, is how you would advise Ms. T further on psychological therapy. That's part 2. So anyone want to fill in this first question, right? Advice to Ms. T that might be appropriate in this case. Ms. T is declining the treatment, but it's felt that she needs this therapy. What sort of advice should be given? Okay, we're not getting, okay, folks aren't quite having ideas about this. Maybe the experts can share how medical advice should operate in this particular case.
So I think in this particular situation, you can see that Ms. T is not very keen to engage with treatment. She probably doesn't see much wrong with herself, and I think she's grudgingly taking medication or refusing it if she could. So psychological therapy probably is part of the range of treatment options that I would certainly consider. And I would want to spend time talking to her and explaining the benefits of psychological therapy together with pharmacological therapy. They work far more effectively together than either therapy alone for OCD. And hear her thoughts about it and any concerns about it, and whether we can maybe work around it. One of the areas often is patients don't really understand very much about the treatments that we are proposing, because if it's done in a very rushed bedside manner, so maybe taking time separately after rounds, let's say, and then or even giving information and reading materials or resources that the patient can look up, and also finding out whether there's anyone the patient can talk to sound out and maybe get views on before they decide on the therapy. So I think that's probably how I will go around advising Ms. T.
So I think earlier I was speaking to Dr. Giles about this as well. Having like an advocate or peer support specialist like that Ms. T could have actually spoken to about this person's own experiences in seeking help and what probably helped this person might also help her feel more open to considering psychological therapy if she hears from someone else who has been through a similar experience. I think a lot of times patients don't really have access to that. They feel like they're alone in their journey, and like here I am being told like what I'm supposed to be doing when I might not always understand or relate to what is being told to me. But having someone who has actually been through something similar, who has tried different forms of treatment and therapies as well, might make it might be a bridge between the healthcare professional and Ms. T as well. Yeah, so I see this as something that could be considered as well. Yeah.
Sorry, interject. Nawira, you mentioned that you've been through some form of psychological therapy before. Maybe what what aspect of the relationship made you want to continue to seek psychological therapy? Or was it the therapist, the characteristics, or how? Yeah, I mean, yeah, I'm curious.
Yeah.
I'm curious.
So I think not just for myself, but having my own experiences, and also for a lot of other peers like myself who have actually sought therapy. I think what really helped was that relationship that you have with your therapist or even your doctor, right? Trust, I think, is very important. Being able to have an open communication and actually feeling comfortable, feeling heard. Even if I don't think that, this person understands what I'm going through because he or she has not been through what I'm going through, right? Actually feeling that my views are heard, even though it might not always be in agreement with what the healthcare professional thinks. So my understanding of recovery might be very different from the healthcare professional's understanding of recovery, but whether I actually feel like it is valued, it is considered. Because I think we talk a lot about clinical recovery, but I think there's also this need to also talk about personal recovery, what recovery means to the individual itself, which might be different from how clinicians see recovery. So sometimes it's not just about the reduction of symptoms, it's not just about whether this person has fewer symptoms now and all that. But I think what it means to the individual, because for that person it might be, am I able to get work in the future, right? Am I able to still do the things that I want to do to have a meaningful and fulfilling life, especially since for Miss T and even for myself, right? We were diagnosed at a younger age. So I think it was important to consider these things as well. What would help me feel more open to seeking help and therapy? So I really think that relationship itself is actually probably even more important than the treatment that I'm getting, the medications that I'm taking. Feeling comfortable with the therapist and feeling that I can have open communication. And I think for a lot of the peers that I also see in IMH, right, a lot of times they say that their wishes might not always be heard. They don't feel the doctor's listening to what they're saying. So I think this is very important, whether the person actually feels that my views, my preferences, my values and beliefs even are even considered. Yeah.
I totally agree that the voice of the peer specialist is very powerful. Yeah, thank you. I just want to I was looking at this narrative. As a social worker, I often hear this from my client, especially for those who have been forced or coerced into coming into IMH. So in this case, it was like the mobile crisis team nurses, and our crisis team nurses are very good. They just have this way of getting and talking to patients to come. But at the end of the day, the patients are actually put in a position where they don't have a choice. So it's still coercive in some way. So they will still come. And many of them, or sometimes they could be sent to hospital via a private ambulance. And you have a few burly, ambulance men, and the patients who have no choice but just have to be wrapped into the ambulance. And very often, patients tell me how traumatic the whole experience can be. And I have a few instances where I have to work on mediating and getting the client to learn to forgive the family for having put them into an inpatient ward, and they felt betrayed. So I think that kind of conversation would actually be very important. So when I see that patients are coming in this kind of manner, I want to have discussions and conversations with them and see what has been experienced for them, because it's this whole issue about I'm being forced here. Can I trust my family? Can I trust the doctors? Can I even trust you, social workers? So if this is going on inside the patient, it is very hard for them to want to consider getting any form of treatment. So I think having conversations and sometimes even mediating and reconciling patients and their families over this kind of so-called misunderstandings or betrayals, I feel it's very important. Yeah.
Yeah, I just want to make a quick comment to add to what Nawira and Lady had mentioned earlier. I think having an understanding of what matters to the patients and actually what their goals are would be very helpful, because then we are working together. So for me as a doctor, for me, it's symptom reduction or eradication of symptoms is the aim. But actually for the patient, that might not be the aim. Actually, I think Nawira mentioned the aim might actually be able to go out and lead a sort of more normal life and maybe make friends and go out or get a job or go back to school. I think she's studying at a private university, maybe to complete her education. So maybe, if these are the these are the goals that she's working towards, and if what I can offer in terms of therapeutic interventions to help her achieve those goals, then I think it's more likely that she will see the relevance of the treatment. So I think the importance of aligning our therapeutic interventions with the patient's own goals, I think is an important element to consider.
Thanks. Maybe we can now get some audience input here via formalized methods using the poll EV. This is a poll concerning a related issue, a related treatment issue. This would be the question, as you'll see when you scan the code. You're deeply concerned there's an underlying medical cause for her bleeding from the rectum, and you feel she needs a scope done. What would the next step be? Get Ms. T's mother to consent for the scope, assess Ms. T's mental capacity to decide on whether to have the scope, or apply to the court to override Ms. T's decision on the scope. Or maybe there's a fourth option, but anyway, those are the three we put in the poll. Okay, this is an unambiguous question. Complete dominance of one option, almost only 2%. I don't know if we can get the 2%, one person to answer that. Get Ms. T's mother's consent for the scope. 96% assess Ms. T's mental capacity. And then I presume, I guess I can infer 1% or less for the apply to the court. Maybe it was implying zero. Zero answers is what that meant. Maybe 0 people said that, is what that means. Okay, so complete consensus pretty much on this. Anyone just want to explain why assessment of mental capacity was indicated in this case, rather than going to Ms. T's mother?
Maybe I'll just start off. Yeah, so I think this is absolutely right. You cannot use Mental Health Act to treat her, clearly, because it's a physical health problem, so the Mental Health Act doesn't apply. You can't use coercive treatment under the Act. So your other alternative is to consider whether you could use the Mental Capacity Act, and if you first need to assess the capacity, and if Ms. T lacks capacity, then you can then discuss what's in her best interest and whether treatment for the rectal bleeding is in her best interest. But unfortunately, you probably can't do very much more. If you assess and she does have capacity, then that would probably be a decision that we have to respect in terms of her decision.
Okay, I think this is a little bit more tricky than it appears. When we talk about assessing mental capacity, yes, we have the 4 criteria, as laid out: ability to understand, weigh, retain, and then reproduce. But it must be considered in the context of the patient's mental health condition. And oftentimes it's not so easy to tease out how much of the decision, that weighing bit, is influenced by that mental health condition. I find that part very tricky. I had a very similar case. The patient was losing weight tremendously, but she wasn't obsessive compulsive disorder. Her condition was just a depression. She had major depression. Maybe a bit of personality issues as well, but she had been losing a lot of weight. And despite my best advice, she refused to seek medical treatment. Was the depression affecting her ability to decide? I'll tell you what happened. She was very fearful of what to do if she found out she had cancer, which was why she didn't want to go and seek treatment. Is that the depression talking? Is that the personality talking? Is it her own upbringing, her own hang-ups talking? I found it very hard to tease out. And I found it very hard to okay, this person has the mental capacity to decide regarding treatment. So I think the point I'm trying to make is not quite so clear-cut how much the mental illness is the one talking or the patient's preference or wishes are talking. How that case eventually ended was, Owen is option 4 lah. Yes. I think that the learning point is there's always an option 4. There's always a 4th option, which we haven't really thought about. Yeah. Okay. So always look for option 4, I think. Option 4 in this case was the rest of the family came in. And it wasn't the immediate family. It was some distant cousin whom she trusted. Yeah. And then the distant cousin brought another distant cousin. And before you know it, all three of them were coming to see me. And I think the active involvement of the other two distant cousins gave the patient that support to finally decide to, okay, I'm going to just go and check up why I'm losing weight and everything. So I felt that was the helpful bit. Yeah, that's just my personal sharing here. Yourself, anything?
Okay. Yeah, thanks. So yeah, the option 4 is always the dominant one here. I mean, in this particular case, it's interesting just to note, the option A, in addition to, not yet having established Ms. T's mental capacity, even if Ms. T lacks capacity, it's not automatic that Ms. T's mother would be the one providing consent in that context. Only I think it would be if there was an LPA, if Ms. T had appointed her mother as an LPA, or if there had been she'd been appointed as a deputy by the court with that default. Otherwise, as we discussed previously, the doctor in charge would make that determination in the instance when Ms. T lacks capacity. Okay, then the third question relating to this iteration of the case, it's a pragmatic question in some ways, but it relates to ethical issues, especially with a patient who is somewhat reluctant for treatment, is how much longer would you keep Ms. T in the inpatient unit? How do we assess the appropriate length of stay in a case like this? Any of the panelists have a...
Okay, I'll have a go. Clearly, the Ms. T is currently detained, right? She's detained under the Mental Health Act still. So we need to review whether the conditions for her detention under the Mental Health Act continue to hold. And this will be primarily in the interest of her health. I mean, she has a mental disorder, but whether it's in the interest of her health or for the safety of herself or others. And if she no longer meets criteria for detention under the Mental Health Care and Treatment Act, then actually we have to remove remove the restrictions of the Act on her. In which case, then Ms. T would then become a voluntary patient. And as a voluntary patient, she would then be able to take her own discharge if she so wishes, a discharge against medical advice. But whilst that is sort of the legal position and the options that we have, I think the broader consideration would be how much therapeutic benefit is there for Ms. T to remain inpatient for treatment. If there is, then you could perhaps justify that the detention under the Mental Health Care and Treatment Act can continue for her health for a little bit longer. And also engaging with the patient again, I come back to the goals that the patient has. And if the patient knows that you are working with her to help her achieve her goals, then probably more likely. Did I cause that? No. She's probably more likely to engage with the therapeutic care plan, that's being developed. So I think the question of how much longer to keep Ms. T really is a balance of what is the benefit of being inpatient, what are the options in terms of the Mental Health Care and Treatment Act being still enforceable, and what are the risks if she were to leave the hospital or be treated as an outpatient. So those are just my initial thoughts.
Thanks. I think Sharon, you wanted to comment on this?
I'm just wondering, what if Ms. T's mom comes to you and says, can you just keep her for a few more weeks? Because I've never had a break before, and it's really good for my mental health. And how much do you think that is actually relevant in thinking about what is Ms. T's best interest to actually be able to go back to a home where her mum is a little bit more rested and has had a chance to recuperate as well?
I'll make a start, and then the rest of the team can share their views. This is not an uncommon request, and it does put us in a rather difficult position, because essentially what we are being asked to is to restrict Ms. T's freedoms which are very significant. She's detained in hospital. She can't go out. She can't do the things that she would want to do. At the request of a family member, and it is for the benefit of the family member, for the mother to have a rest. So we are restricting Miss T's liberty and imposing all these restrictions on her for the mother's benefit. Yes, for the mother to have a long break. I fully appreciate caregiver burden is a very real thing, and we need to support mother. If mother needs a break, we really need to assess what her needs are, and she needs support and help in that area. Sometimes what I often do is to just have a family session and just talk to the patient and the family and just air the challenges and the issues, and also see what compromise we can come up with. It may be that if Ms. T doesn't need inpatient treatment anymore for her own health needs, then she could perhaps go to some step-down care facility. So that would then achieve the aim of her not being restricted in terms of being detained in hospital, and also she doesn't go home where mom would then feel exhausted, so mom does continue to have a break. So I think we can work things through, but I think we really need to have engagement on involved parties really, and come to a arrangement that generally works for everyone. We probably don't have a perfect solution most of the time, but one that is workable. I mean, that would be my approach, but I'm keen to hear the rest.
Social worker talking. How long will we keep Ms. T? I think a few things needs to be sorted out before the discharge. We need to assess the caregiver's well-being and safety. I mean, she has been forced to hit herself and going through a lot of distress at home, so we need to kind of like check on her well-being and safety. We need to address the patient's, Ms. T's intimidation towards the caregiver. We need to let her know that this intimidation towards her mom is not okay, and how can, there needs to be a commitment that this cannot continue if she were to be discharged. Through probably also working out a safety plan and ensure that we can also bring in some community stakeholders to handhold us to follow up with the patient after discharge. Yeah.
I would also think that, like supporting the mom, exploring like what kind of resources, like even caregiver support that she needs. But from Ms. T's point of view, right, I'm also thinking like, especially since she doesn't want to be in the hospital, like how much of that is going to impact her future in the long run, right? So like even helping her readjust or maybe even reintegrate into the community if it's a longer stay, I think that is important. So like what happens after the admission, right? Not just during the admission, but like how do we support her in getting back to her usual routine and usual life as well, if a longer stay is required in an inpatient setting. So I think, especially since Ms. T is also unemployed and all that, and also like helping her readjust to like, the things that she wants to do in life, the things that she haven't done in her life, like I think that's important. Like, so even like reintegration into community, especially if it's a longer stay. Yeah.
Okay, I'll just chime in here. Dr. Giles is right. It's a fairly common problem where the caregiver says that I need a few weeks more. I'm not prepared to bring home my child or my husband or whatever. And sometimes they even tell the doctor, you don't say it's I say one, huh? You just keep the patient, but you don't say it's I want the patient to be kept in. And then you find yourself a little bit trapped. Do you, what do you say? Sometimes family members also go to the meet the people session, and very often I receive in the middle of the night, right, an MP letter, so and so, has requested that you keep their so and so for a bit longer, and then your hands are a little bit tied. Okay, what should I do now? There's a bit of a political pressure as well, just to add a bit of complication to the mix. For me, for this situation, as Lei Ling alluded to right at the start, right, this is a very fractured family system. Okay, and there needs to be some healing. And if that healing involves, okay, everybody let's just take a break from each other for a while first, whilst we try and find some ways to just put the pieces together, I think that extra few days or the extra few weeks is a golden opportunity for us to tap on. And I mean, the mother don't come, yes, the mother don't take the patient home, yes, fine, but I still expect the mother, you still have to come. You still have to visit. You still have to show that you care, and then we observe the interaction and then build that relationship. So I think buying that time, yes, it may not be ostensibly therapeutic for the patient, but what it can possibly do for the family as a unit and the healing, I think that also cannot be measured, but I think it's also important that we should consider. So, yeah. And obviously avoid MP letter, So, yeah.
Okay.
So Marcus, can I ask you then, would you keep this patient under form, under the Mental Health Care and Treatment Act, so that she stays in hospital?
Now, to justify the use of the Mental Health Care and Treatment Act, I mean, there has to be very clear criteria. I don't think, given the circumstances, that she can be still on the form. She can still be on the form, but I would try some way or means to persuade her, and that to stay just a little bit longer, just to see for the eventual recovery, hopefully, yeah.
Yeah, I just wanted to backtrack a bit. I mean, about, maybe sometimes both parties, like both the family and the patient, might also need space from each other, right? A lot of times, I think patients might feel like my family or my caregiver, or whoever it is, doesn't understand me, doesn't understand what I'm going through. But sometimes it takes trying to understand your family as well. And I think this takes time as well. But I believe in having even a family session or that open communication, even though it might be difficult at times, within that family, can actually be quite healing, because I speak from my experience as well. Even though there were times with my own family, it wasn't easy for me to understand what they were going through when I was unwell. It was also not easy for them to understand what I was going through, right? So I think having that really open communication, even if you trash it out with each other, you're not happy with each other, but I feel over time, being able to actually speak about things in a calm manner actually helps.
Yeah, thanks. We have another case, another twist to this case, more twists than a K-drama. So we have a third iteration that's going to be circulated in hard copy now. So while that's been circulated, just a side note, very interesting things about discussion about retention of patients. One thing that I'm always reminded of when I discuss this topic, whenever we don't have any legal scholar or legally trained folks, I guess, on stage, but the lawyers always remind me, if you are retaining somebody in a hospital without any lawful basis, that's kidnapping. So just always be a little careful. Okay, part 3 of the case, which again I'll read out a little slowly as it's being distributed, and it's a natural extension of some of the topics we've been discussing. Ms. T was discharged to the care of her mother. The following day, Ms. T tried to climb over the parapet of her home. That is, she attempted to jump. She had been planning since hospital admission to kill herself, as she could not forgive her mother for sending her to IMH and having an IMH record. She felt betrayed by her mother and opined that the latter ruined her future. She always had wanted her mother's approval and wanted to succeed for her mother's sake. Ms. T's mother calls the police, and Ms. T is brought to IMH again. This time she was admitted involuntarily due to the suicide attempt. In the ward, she refused to speak to her mother, and she verbalized she did not want any psychological medication or therapy. She was vehement against taking any medications, and she told the treating team just to let her go home so that she could end her life. As an inpatient doctor, according to Ms. T, would you administer medications against her will or covertly? So one option is yes, administer against her will in her best interests, or administer medications covertly in her best interests. So one is kind of forcibly, the other is covertly. Or option C, no, not administer medications because I should respect her wishes. D, no, not administer medications covertly because this would be deceitful. Or probably there's a fifth answer. There's always another answer here. But you can reserve that in the comments for other alternatives. Okay, so more spread. No option had a majority, an outright majority. There was a plurality answer. None of them was completely locked out. None of them were completely locked out. Okay, so yeah, the plurality answer, I guess, was B, the covert medication option, coming in right behind that. So it's combined, the majority answer combined would be yes, either overtly or covertly supply medication in the best interest, though a few, roughly, I guess, 20% total, were against providing medication with either method. All right, so anyone want to give an explanation for their preferred approach in this case?
Talking about autonomous reply, it doesn't exist. Okay, just the remark. I think I chose the first one. I will administer medication in the best interest. But in bracket, either overtly or covertly. Reason for that is that because they give me leeway to decide which path. Just like our panel will say, there's always a fourth or fifth choices.
Thanks, but it still would be either one of the administration of medication one way or the other, I suppose, in this case. Okay. Anyone who said no, I was curious, anyone who gave a negative answer here thought that neither approach is going to be appropriate and actually medications should not be provided and the patient's wishes should be respected. No? I mean, it's interesting. I mean, I don't think we should dismiss necessarily any of these answers. A lot of these issues are tough calls. Looking after the best interests of the patient is not always straightforward. And even the law might look black and white, but interpretation of when have that flow chart looks pretty clear in some sense, but interpretation of when MHCTA or when mental capacity act are triggered is often unclear. Okay, maybe I can put it to the panel though, and see the panel's take on these options. Did you have a consensus in here, or is it again option number 5?
I have mixed feelings that the covert medication is the most popular option. I feel very conflicted about that. Maybe I was convincing enough, right? But you all remember the last part of the talk, right, where I said that the singles like the MOH, they cannot, right? Yeah, that's MOH, they cannot, huh? So, okay, just to reinforce the point, I think given the circumstances, right, she did something really dangerous. She climbed the parapet and everything. So I think this person would probably be under the Mental Health Care and Treatment Act. Okay, so as the gentleman in green mentioned, there is no need for covert medication. You can administer you can administer against the patient's will. Now, how you do it, how you administer the medication, the administration plan, right? That one is a question mark as well, but it's something that has to be discussed. In the previous admission, she was compliant to treatment, so I don't know how. I mean, she just took whatever the nurses gave her. So there may not necessarily be a need to resort to covert medication, and that's why I think about this. Yeah.
Did others on the panel have a thought about which was the best option? Did you all agree that medication one way or the other should be given in this case?
Sorry?
Did you agree that either A or B, at least one of A or B, would be appropriate, or do you think actually maybe medication shouldn't be?
Yeah, so I'm going to follow Marcus's earlier strategy of suggesting an option 5, in that is there a need to press on with medication immediately at this point? Because our primary overriding concern at this stage is actually to keep the patient safe and also to help her recover and reduce her risk over time. I probably wouldn't jeopardize the therapeutic relationship immediately by forcing a Rouse tube down her throat and putting medication in. That would just completely destroy, any sort of working relationship we have. If I have some time, if she's not actively very suicidal on the ward, then actually I do have time to actually engage her a little bit more. Maybe involve her family or friends whom she can trust, those that she can engage with. Try to get allies on my side as well. Try to address any concerns she might have. So if the risk is not so high, that there is very imminent risk to her life and there is some time, then I probably would say medication is necessary, but I would not compel her to take it at that point in time, even though under the law, I probably could invoke the Mental Health Care and Treatment Act and force medication. But if the risk is very high, then sometimes our hands may be tied. We might not have the luxury of time to form that engagement. In very extreme cases, we have even had to use ECT, electroconvulsive therapy, on extremely depressed patients who were probably very physically unwell as well because they were not eating or drinking. So there are circumstances where we are compelled to act very quickly, but when circumstances allow and there is a bit of time, then I would try to make best use of that time to get the engagement.
I think, can you all hear me? It's working, right? Yeah, I think in this situation, of course, there's a need to preserve life, right? But I'm just thinking about, like what happens after this, right? Like, let's say she finds out, and then like, that how it jeopardizes that trust she might have, especially since she already feels that her mom betrayed her, and then now like this healthcare professional actually gave me meds covertly, and like, so I'm just thinking from that perspective, like, how do we repair the relationship if there's a need to? So I'm just. Yeah, I mean, I cannot imagine if this happened to me as well, like how it will impact me. So like, I'm just speaking from that point of view as well. I think that trust, especially, if you have already established that trust with your doctor, right? And then suddenly like this is done, like, I guess like having, someone to explain why this was necessary, like, and like, to have that conversation even after this was done, right? I think that would be a bit helpful and less traumatic for someone.
Yeah, I think I didn't comment on the covert medication because I think for me that's just something I feel very uncomfortable doing. So it didn't even sort of become one of my options. So I would either have to treat coercively, overtly, with the patient's knowledge, or not treat at that point in time. And I think I fully agree with Nawira. I mean, when the patient does find out, and invariably they do, it completely destroys any trust that the patient has with the healthcare professional. And also, it poisons the relationship with the family because the family were people that they could trust before, and they took to look after their interests, has actually done something pretty devastating and pretty, it is a strong, it's a betrayal really. So I find that very, very difficult. And I think it's the day after, so what if we get her through this episode? But what about the day after? How are we to maintain the care plan, the treatment plans that we want her to engage with? So maybe this is my personal view in that covert medication really should be the last resort. And I personally wouldn't use covert medication, and I would seek all other means to engage the patient. And if risk is very high, then we may have to act quickly against the patient's wishes without their consent within the what is permitted under the law.
Thanks. There's another question, though I guess this actually overlaps with the question, with the last one. I might just gloss over it quickly, but so there's this question of detention length. So again, just as a reminder, what is the standard here for how long Ms. T could be retained in IMH?
Do you mean detention under the Mental Health Act?
Yeah, so she's presumably being held unwillingly in this case because she requests to be discharged. So how long in that case? When would the discharge occur?
Right. So if she's initially held under Form 1, which is for 72 hours, and at the end of that, before the end of that really, she has to be assessed whether the risk to herself or to others is still very high, or her health needs necessitate inpatient treatment, and if so, then she can be detained under Form 2, which allows detention for up to a month. And so I think, if she continues to meet the conditions for detention under the Act, then the mental health act can continue. But if she no longer meets the criteria, then she has to be taken off the act, and then she then transits into as an informal patient, as a voluntary patient. Of course, beyond that, as I mentioned earlier, is there therapeutic benefit as an inpatient? So that's something which we need to continue to engage with. But then, as brought up by others as well, there are many other factors that influence the length of a hospital stay. Many times, it's actually social reasons that prolong a hospital stay, and I think I think it's across the board. I think all institutions have overstayers and have discharge challenges, and I think that's perhaps the area to work on if we then want to facilitate the discharge.
Thanks. The next question we sorry, did you want to answer that? Sorry.
Like how long? I think we really need to monitor her suicide risk, and we need to have that risk down and some decent safety plans worked out before we can consider. This is actually my client. Of course, I've changed personal data so that you cannot recall. I recall when the patient first came in, and she just said she wanted to die. After like 7 sessions, now she's saying that she's prepared to talk about her suicidality. All right, and she's prepared to talk about how not to be suicidal, but she's not prepared to consider family reconciliation. So it's really about building rapport. It took me 7 sessions for her to want to work on some decent goals with me. So really, it's about keep talking and earning the trust, but it has been quite not very easy, yeah. But when every session is like, so when am I going to be discharged? So it's really quite challenging, but really about building that rapport and building trust, yeah.
Thanks. And the next question was a more in the weeds question, but about an alternative. We've been talking about medications, covert medications, overt medications, but what about more invasive treatments like electroconvulsive therapies? Is the same standard going to apply as with medications that we've been talking about, or is electroconvulsive therapy going to be a different standard concerning when the patient is, again, refusing that particular therapy?
Okay, I'll give my comments first, and then Marcus can continue. So electroconvulsive therapy would also come under the remit of treatment. And so if a detained patient requires treatment for mental disorder, then ECT can be prescribed. I think our local Mental Health Care and Treatment Act is a bit different from the UK Mental Health Act. The UK Mental Health Act has added more safeguards when using ECT. I think you need a second opinion, and there are more safeguards. You could probably authorize initially 2 emergency ECT shots, but beyond that, you need second opinions to support it. Our local Mental Health Act does not have these additional safeguards or requirements. So for all intents and purposes, ECT would be sort of deemed as equivalent in terms of mental health treatment as with perhaps even medication. But of course, the patient would need to meet the indication for ECT. So ECT is only administered for specific indications like manic patients or very profoundly depressed patients, or even in some occasions for psychosis. So I would say that for ECT, if the indication is there, I would refer her for ECT for her therapeutic benefit. If she refuses to give consent and the risk is high and I feel she really needs it, then that can be done under Mental Health Act.
ECT or electroconvulsive therapy, it actually works, okay? And you may actually see marked improvement in the person's mood, functioning and everything. And when that happens, then the person can better engage with therapy, build the relationships with the mother, etc. But obviously the opposite could also happen. She has been subject to a lot from police being arresting her, the mobile crisis team admitted and discharged, and the whole, probably stormed as well and everything, and then this finally comes to IMH. ECT would be just an additional, could be viewed as another trauma to whatever she's already experienced. It's kind of like a series of unfortunate events that just keep spiraling out of control. yes, this is a real case, Lei Ling's case no less, with the de-identified obviously. But I also like to say that not all the cases are so overtly, for lack of a better word, tragic, as it were. There are positive outcomes. Relationships do get built, feelings do get healed, and people do become better. Because I mentioned a series of unfortunate events, I just want to very quickly share one story. My patient is an elderly lady, all right? So her daughter is also a mental health patient. My patient has got some cognitive impairment, but the daughter has got bipolar disorder. The patient was overseas, stopped her medications, relapsed there. This poor old lady had to fly all the way there, rescue her daughter from a mental institution in the other country, and bring her here. Naturally, when the daughter touched down in Changi Airport, the mobile crisis team was there. Everybody was ready to ferry her to the Institute of Mental Health. But my patient, the elderly lady, she decided that, no, this has gone far enough. I'm going to take a big risk. I'm going to bring my daughter home. I'm not going to subject her to any more of these things. I will do whatever I can. I'll engage with the doctor separately, whatever. I don't want to subject her to any more of these things. Okay? And lo and behold, miraculously, slowly but surely, the daughter got better. The daughter has a good relationship with her mother, in fact, even better now, because the mother rescued her and saved her from all these other things. So there is no magic crystal ball which we can figure out what's going to happen 5 years after this ECT was given. We will never know, you know. But it really could go either way, and it has gone either way before on separate occasions. Yeah, so I just thought I'd share that just to add a bit of hope. That it's not just call police, admit, covert administration, and then ECT, and then, you know, there's an option 4 or 5 or whatever. Yeah.
Thanks. And we also have a question just to bring back the familial and the relational context into the picture here. Ms. T's mother, there was this request, Ms. T's request not to speak to her mother about it, but would you speak to her mother even though she clearly stated she didn't wish that? Or would you get her mother to decide, for example, inputs regarding those treatment options that we were just discussing? So what about Mrs. T's mother in this context?
Considering that Ms. T's came in wanting to kill herself, and even in initial session, she was talking about wanting to end her life. With a presentation like that and a high risk of self-harm, we cannot not involve the next of kin to discuss and to understand what is going on, what's the relationship like, the history of the relationship, what kind of attachment, you know, injuries have actually has actually happened between mom and daughter, and also really working on how mother can help us to keep her daughter safe, what kind of approaches might work with her, and also talking with the daughter. So I would say that we cannot not work with the mother, because eventually the young lady is going to go home and mom is going to be a caregiver. So we cannot work with her in silo. Yeah, that's my.
I think, I recognize that, Ms. T also doesn't want you to speak to her mom and all that, right? I'm just wondering, if there's a way to actually work with Ms. T to then hear from her how she wants to be involved in your discussion with her mother. Why is she even hesitant for you to speak to her mom, right? Is there a way that you can better involve her in speaking, maybe even a joint session, right? So I was thinking along those lines as well. Because I think she really feels betrayed by her mom, and if we were to do this, how much more betrayed would she feel? And as an adult, how can we then involve her as well, to the extent that is possible? So I'm just thinking,
Thanks for raising this. I believe that whatever we do, we are transparent about it. We don't involve the mom behind her back. So we may have, try to talk to her to help her understand where we're coming from. And if you really want to be discharged, we really need to work on some of these things. I also want to have you home. And so I think it takes time, but it's important that we don't do it behind her back, even in the area of engaging her mom. Yeah.
Maybe I'll just add to that. I think the first thing that came to my mind was respecting her confidentiality. If she didn't want me to talk to the mother, then I probably would want to clarify with her it's because she doesn't want mother also to know about her condition, which is her medical information. And anyway, so I think it's I would support that. I mean, I wouldn't breach her confidentiality if she doesn't want me to update the mother about her condition. I think I will respect that. But if it's to speak to mother, and I get this very often, they say, don't talk to my family because they forced me to come into hospital. I'm very angry with them. And then say, fair enough, you don't want us to share your information. But is it all right for me to talk to them just to get their feedback about what has actually happened so that I can better understand what you went through and what I can do to help you? And if it's sort of me just receiving information, then I'm not breaching my patient's confidentiality. So I will try to do that. Then the other area that I will try to explore further is what are your discharge plans and that sort of thing. And if it involves going back home, as Leilin mentioned, and the family is involved, then we really cannot leave the family out of the equation. So it would be some negotiation as to how and to what degree and level of engagement with the family. And again, I'm a fan of doing family sessions. It's very time consuming. And sometimes it can be a little bit acrimonious depending on how things are. But I think it's very helpful if they are agreeable to actually all sit down and just talk things through. When facilitated by members of the team. So in this case, I would respect patients' request for her confidentiality. But I would seek to engage the family more in terms of care planning perspective. And if the patient can be involved in that process, I think that would be even better. Whether I would get mother to decide on ECT options, I would seek her views, mother's views about what she perhaps would have felt patient would have wanted, and what the mother's views are as well. But mother wouldn't be in a position to give consent in any case. That'd be my view.
I just have one final point to add, and this is, which is this: we talk a lot about patients' autonomy, patients deciding for themselves what's best for them. But remember, we are also healthcare professionals, many of us at least, and we do come with the clinical experience working with other patients. We know, what the potentials, we know what the pitfalls are. It is also, I feel, on us to guide that decision-making process in the sense that not that we tell the patients what to do, but it is also a responsibility given our knowledge and experience that we point or maybe or guide the patients in the what we feel might be the better direction. So yes, we respect autonomy, but we owe that duty to them because of what we know and our experience and everything. Yeah.
Thanks very much for those inputs. So now we're ready for part 4. No, I'm kidding. We're done. We're at 5 now. So thanks very much for our panelists. Do stay up here. I have a few just round-up points and some slides to summarize. Well, the slides were prepared ahead of time, but just to try my own takeaway from this very rich and engaging discussion. We talk a lot, and we have some more information on the law, the legal restrictions and permissions for those that have mental illness and those who lack mental capacity. But it's important to reiterate, right, that law and ethics and professionalism, right, can come apart. And just because you are legally empowered to do something, to detain a patient, to perform treatment without their consent, does not mean it is ethically permitted, or that, moreover, does not mean it is necessarily in their best interests, right? So we need to go well beyond the law to understand what is the appropriate action in this case of Ms. T and in these sorts of cases that we've been discussing. The law sets a sort of minimum threshold or minimum guardrails around what we're allowed to do. But a lot of the nuance of this discussion, how to engage with the patient's family, doesn't come from black letter law or even that flow chart that was flashed up earlier. But there's just a few reminders all in the bit that is black letter, right? So we have the legal standard, right, that a person with a condition, with a psychiatric condition may make unwise decisions or express different values and preferences, and we should still respect those preferences to the extent possible. And just because someone has a condition doesn't mean that they are no longer an object of respect, a person of respect, I should say, sorry, whose values are relevant and opinions and values about their own life should be taken into account. We talked about the standard under the MHCTA of detention, right? And it's only if the person is a danger to themselves or others, and that's attributed to a mental disorder. And there needs to be a degree of imminence as well, right? So merely refusing treatment for, say, a chronic condition might not be sufficient for that. So they mentioned the LPA. Having an LPA often will, clarify who the decision maker is, although that does not apply to treatment that is relating to sustaining a life or preventing serious deterioration. There's a bullet here on covert medication, though this was drafted, a little bit earlier, and maybe you should take the wording here with a grain of salt. As noted, MOH, I guess, has signaled that covert medication is frowned upon. So even if it looks like a majority of folks are comfortable with it, the deception involved is not only kind of intrinsically disrespectful, as an act of dishonesty, but can undermine that trust, that trusting relationship. So even if you think, well, it's much easier, it's just faster, it's more convenient to put it in the yogurt or the cereal or whatever, it can have longer-term consequences that ultimately might be against the patient's best interest, in addition to being disrespectful to them and possibly their family. And finally, we shouldn't forget, people are not an island, right? People live in relational lives with their family members and other loved ones, and those family members, those other loved ones, should not be making treatment decisions, but not necessarily making treatment decisions unless there's been an LPA appointed, but they are nevertheless important for them to be consulted, to them to be involved in decision making to the extent reasonable within bounds of confidentiality, and especially when patients themselves welcome that as a matter of shared decision making. Okay, I'm going to close the panel there. Again, thank you very much to the panelists.